The thyroid, an overview. The thyroid is an endocrine gland located in the front of the neck, responsible for producing thyroid hormones that regulate metabolism, growth, and many other bodily functions. It plays a vital role in energy production, heart function, and overall well-being. Thyroid disorders can lead to either overproduction, hyperthyroidism, or underproduction, hyperthyroidism, of these hormones, causing various symptoms. The thyroid is a butterfly-shaped endocrine gland located at the base of the neck, in front of the trachea. It plays a central role in metabolism, growth, and energy regulation by producing hormones, such as thyroxine, T4, and triiodothyronine, T3. Under the regulation of thyroid-stimulating hormone, TSH, from the pituitary gland. Thyroid hormones influence virtually every organ system, regulating body temperature, heart rate, energy utilization, weight maintenance, and even brain development in infancy. Any dysfunction of this gland, whether underactive, hyperthyroidism, overactive, hyperthyroidism, or neoplastic, can significantly affect health. Thyroid cancer. Essentials. Thyroid cancer arises from abnormal growth of thyroid cells. While most thyroid nodules are benign, a small percentage progress to malignancy. Thyroid cancer is among the most rapidly increasing cancers worldwide, partly due to improved imaging that detects small nodules. Types of thyroid cancer. 1. Papillary thyroid carcinoma, the most common type, usually slow-growing, with excellent prognosis. 2. Follicular thyroid carcinoma, less common, may spread to lungs or bones. Prognosis is still favorable if detected early. 3. Medullary thyroid carcinoma, arises from parafollicular C cells, can be sporadic or hereditary, requires genetic testing for RET mutations. 4. Anaplastic thyroid carcinoma, rare but aggressive, with poor survival outcomes. 5. Other rare types, such as thyroid lymphoma and poorly differentiated carcinomas. Risk factors for thyroid cancer. Genetic factors, family history, inherited syndromes, men too, familial medullary thyroid carcinoma. Radiation exposure, especially during childhood or adolescence. Gender and age, more common in women, with peak incidence between ages 30 to 50. Iodine intake, both deficiency and excess, can predispose to thyroid dysfunction and malignancy. Environmental exposures, carcinogens, pollutants, smoking. Other thyroid conditions, long-standing goiter, Hashimoto's thyroiditis, or nodular disease. Symptoms and clinical presentation. Thyroid cancer is often silent in its early stages. Common clinical features include a painless lump in the neck, hoarseness or voice changes, difficulty swallowing or breathing, swelling in the lymph nodes of the neck, persistent cough not related to respiratory infection. Diagnosis and evaluation. Evaluation is systematic and includes clinical examination of the thyroid and neck, ultrasound imaging to determine nodule characteristics, ultrasound imaging to determine nodule characteristics, fine needle aspiration biopsy, FNAB, to establish cytology, blood tests for thyroid function, calcitonin in medullary carcinoma, and thyroglobulin, CT, MRI, or PET scans in advanced disease for staging and metastasis detection, genetic testing for hereditary syndromes, prevention and control. While not all thyroid cancers can be prevented, strategies can reduce risk. Avoid unnecessary radiation exposure, particularly in children. Maintain adequate iodine nutrition through balanced diet or supplementation in deficiency-prone regions. Family screening for individuals with hereditary medullary thyroid cancer or MEN 2 syndrome. Public health education on early symptoms, and the importance of neck self-examination. Environmental control, reduce exposure to carcinogens and endocrine disruptors. Management strategies. Management is tailored to cancer type and stage. 1. Surgical management. Total or near-total thyroidectomy for most cases. Lobectomy for small, low-risk cancers. Lymph node dissection if nodal involvement is suspected. 2. Radioactive iodine therapy, RAI, used after surgery to ablate residual Thyroid tissue or treat metastatic. Disease in differentiated cancers. 3. Thyroid hormone suppression therapy. Lifelong levothyroxine is prescribed after thyroidectomy to suppress TSH, reducing recurrence risk. 4. Targeted therapies. Tyrosine kinase inhibitors, sorafenib, lenvatinib, for advanced or RAI refractory cancers, vandatanib and cabozantinib for medullary thyroid carcinoma. 5. External beam radiotherapy and chemotherapy, reserved for aggressive or unresectable tumors such as anaplastic thyroid carcinoma. 6. Follow-up and surveillance. Regular monitoring with thyroglobulin, calcitonin, imaging, and clinical exams. Lifelong follow-up due to risk of recurrence. Summary and conclusions. The thyroid is a vital endocrine organ, and while thyroid cancer is increasing in incidence, most types have an excellent prognosis when detected early. Prevention strategies such as minimizing unnecessary radiation, ensuring adequate iodine intake, and screening high-risk groups are critical. Treatment revolves around surgery, radioactive iodine, and thyroid hormone suppression, with targeted therapies providing options for advanced disease. Vigilant lifelong follow-up is essential for sustained control. Measurable action plan. 1. Public health. Awareness. Launch campaigns. Encouraging neck checks and awareness of thyroid cancer symptoms within communities. 2. Early screening programs. Integrate thyroid examination into routine health checkups, especially in high-risk populations. 3. Nutritional interventions. Strengthen iodine fortification. Programs in regions with deficiency. 4. Healthcare provider training. Equip clinicians to recognize suspicious thyroid nodules and promptly refer for FNAB. 5. Research and surveillance. Establish cancer registries and monitor incidence trends to guide policies. Signs and symptoms. Most people with thyroid cancer do not have symptoms at the time of diagnosis, and thyroid nodules and thyroid cancer is usually found incidentally on imaging of the neck. Up to 65% of adults have small nodules in their thyroids, but typically under 10% of these nodules are found to be cancerous. Sometimes, the first sign is an enlarged lymph node. Later symptoms that can be present are pain in the anterior region of the neck, and changes in voice due to an involvement of the recurrent laryngeal nerve. Thyroid cancer is usually found in a euthyroid patient, but symptoms of hyperthyroidism or hyperthyroidism may be associated with a large or metastatic, well-differentiated tumor. Thyroid nodules are of particular concern when they are found in those under the age of 20. The presentation of benign nodules at this age is less likely. Thus, the potential for malignancy is far greater. In conclusion, thyroid cancer, though potentially life-threatening, is one of the most treatable cancers when identified early. Prevention through lifestyle, environmental protection, and iodine sufficiency, combined with robust health systems for diagnosis and management, can significantly reduce its burden.
If you find this video helpful, like, subscribe or follow My Health by Dr. J for more important health videos.